No, honey, no.
Hi, everyone. We're just waiting for a few more people to log on and then we'll get started. All right, we'll go ahead and get started now. Good afternoon, everyone, and thank you for joining us for our Lessons in Dementia workshop on Alzheimer's medications. My name is Caitlin Green, and I'm the Alzheimer's Services Coordinator here at the Adult Day Health and Alzheimer's Services Program through the Humboldt Senior Resource Center. For those of you who are unfamiliar with our program, we are a therapeutic day center that provides care for adults 18 and older with physical and behavioral health conditions and provides respite to family caregivers. And our Alzheimer's services portion of our program, in addition to educational opportunities like our Lessons in Dementia and our Dementia Care Workshop, we also provide one-on-one consultations with family caregivers and other professionals, offer resources and referrals, and we have a resource library here as well that we can provide free educational materials. Today we have Celeste, a geriatrician at Open Door with us, and she will be talking to us about 2 medications that were recently approved by the FDA. She has welcomed questions as the presentation progresses, and so please feel free. All right, Celeste, I'll go ahead and pass it on to you.
All right. Hi, everyone. I'm Celeste. So I'm a geriatrician over here at Open Door. So I specialize in the care of older adults, usually at least over the age of 65. I did a fellowship in geriatric medicine. It was actually out in the East Coast in Virginia, but I worked at the Memory Center there a lot, and we were doing a lot of research there, and we actually participated in a few of these drug trials. So I had some experience with them. And when I talked with Caitlin and Wendy about what were the most requested topics or things that people wanted to know about, treatment options for Alzheimer's was at the top of the list. So I kind of wanted to talk about these drugs because there's been a lot of news coverage of them, a lot of hype, a lot of controversy. So we're not going to get to the bottom of everything today, but I thought I'd do kind of a little bit of an introduction about what these drugs are, how they work, what they do, so we can kind of better understand what they are and how they work and whether they'd be a good option for some people. So to start off, oops. Now this is embarrassing. How do I send the slide forward? Oh, there we go, found it. Okay, excellent. So I just wanted to start off to make sure that we're talking about the same thing and kind of define some definitions. So in general, dementia is a general term. It's for when a person has developed difficulties with reasoning, judgment, and memory. And they have to have problems in more than one domain. And they also have to, these problems have to be severe enough that it interferes with a person's independence and daily activities. A lot of people think that when we diagnose someone with dementia, when we talk about how severe it is, it's based on some kind of cognitive test that we give. And while those can be, clues about what's going on, really the big things that are needed to diagnose someone with dementia and to tell how severe it is how much it affects their day-to-day living, and how much it affects whether they're able to do things for themselves and how much help they need. So it really is kind of a disease that we measure clinically, meaning on what the symptoms are and how it affects people's day-to-day life. Dementia can be caused by several diseases that affect the brain. The most common cause is Alzheimer's disease, and it is present in approximately 7 to 80% of all cases of dementia. And I kind of wanted to bring this up because there's really been a shift in how we think about dementia. We used to kind of put people into boxes and say, you have this type or you have this type. And we're realizing more and more that it's often a mixture of more than one type. That's actually very common. So we used to say, if you had a stroke for your symptoms, you're vascular dementia. If you had, amyloid, then you were definitely Alzheimer's. And we're moving much more towards a picture of, you have dominantly this type, but there's other factors that contribute to that. And in a lot of people, it is a combination of more than one thing. So there's a big move in geriatrics and in neurology to kind of define things by that they can sometimes be an aggregate of several different things going on. Oh, there we go. So what is Alzheimer's disease specifically? It's a neurodegenerative disorder. So it's a brain disease. It affects memory, thinking, and behavior. It is a progressive disease, meaning that it does get worse over time. And it's very variable in how it expresses itself, what symptoms people have, and also in the rate of progression. Some people progress very rapidly. Other people have a very slow progression over years and years. On average, a person with Alzheimer's lives about 4 to 8 years after diagnosis, but you can live decades, as long as 20 years. It's currently the 7th leading cause of death in the United States. So it was first described back in 1906 by a doctor that is named after Dr. Alzheimer. And he was the first. They had a lot better microscopes at that point. And he was the first to really notice these microscopic changes in the brain. So he had a patient that likely had early onset Alzheimer's disease. And when they passed away, he dissected the brain and got a really good look with the microscope. And he was the first one to really describe these microscopic changes. And these changes are what are still how we sort of define Alzheimer's disease, and they became known as plaques and tangles. Is everyone here familiar with plaques and tangles? Have they heard that term before, or is that something new? So I see some people nodding. So I'll go over this kind of briefly because I think it sounds like, but based on a couple of people that were nodding, it sounds like something that people are familiar with, but feel free to stop and back me up if you've got questions about this. Basically, there's 2 types of proteins that cause these aggregations in the brain, and we know that that's related to Alzheimer's disease. The beta amyloid plaques, so it's a protein, and there's this cascade that happens. So there's a protein that breaks off and then it aggregates with other proteins and clumps together and makes these sticky plaques. And that's really in between the cells. And that causes a lot of problems. The cells aren't able to signal normally between each other. There's also probably an inflammatory response that's triggered by them, and that can actually kill those neurons or nerve cells. The other one is tau tangles, and these are actually inside the cell, and they have a very big effect on brain function. The cells, when the tau tangles, they disrupt the normal cell machinery, how they move things around, how they get rid of waste and things like that. So ultimately that causes the neuron to die as well. So plaques and tangles are normal. They do accumulate as we age. And as people get older, they do have more of them in their brains. And even people with healthy brains without any type of dementia do have plaques and tangles, but they're present in much, much higher amounts in people with Alzheimer's disease. This is just a picture representation, but again, you can see that the plaques are sort of outside the neuron cells here. If I move my cursor, can you guys see that? Okay, good. And then inside the cell, we have those neurofibrillary tangles. So it used to only be possible to see these plaques and tangles by microscopic examination of the brain. And when I was in medical school, they taught us that the only definitive way to diagnose Alzheimer's disease is on autopsy. Obviously, after a patient has passed away, then you look at the brain tissue. That's not really true anymore. We now have some really good ways to tell if those proteins are in the brain without having to dissect the brain and look at it microscopically. One of the exciting things is we have these PET scans that target amyloid and tau proteins now too. That's a little bit newer, but we can do these highly sophisticated scans that look specifically for the beta amyloid and will light up and show us if there's large amounts of this beta amyloid in people's brains. And then we also really exciting stuff with biomarkers. Basically, that we can do it in the CSF, where we do cerebral spinal fluid, where they do a lumbar tap, like someone who's getting an epidural, and we can look at that fluid and we can look for certain proteins, and that's very much predicts how much beta amyloid people will have in their brain. And then on the forefront, this isn't widely available yet, but there is some really exciting biomarkers that are in the blood, which would really open up the field hugely, because the biomarkers that are found in CSF are pretty reliable, but that's a big procedure to, not a big procedure, but it's, there's a higher burden to do that. You have to have someone who's trained how to do lumbar punctures, whereas if it could just be a blood test that you could order, with your normal screening labs, that would really open up the field. So there's really promising research. There's nothing quite available yet. They're currently kind of arguing over what the cutoff values are and what their role is in everyday practice. But I suspect that'll be in the next couple of years. So the PET scans and the biomarkers are currently being used in research centers. So when I worked at the Glennon Memory Center out in the East Coast of Virginia, we would do these kind of tests a lot, but they're really not used in everyday primary care settings. They're really only used at research centers. There's a lot of debate about what their role is in like primary care. I think there's a lot of concern because these biomarkers can show up years before people have symptoms. I think a lot of people are very concerned about letting people know about this diagnosis, even when we don't have a very effective treatment available. And so having them anticipate this diagnosis. And there are some people that do have amyloid that don't develop very severe disease too. So figuring out what the significance of these biomarkers are, how likely people are to develop disease, and if we have anything to offer them if they're positive, are all kind of being hotly debated in geriatric circles. When you go to conferences, this is what everyone's talking about. It's a very exciting time. So I'm going to talk first about aducanumab. Have people heard of this drug at all? So I'm seeing a few nods. So it got a lot of attention recently. It's actually been around for a while. So this is the cover of Nature back in 2016, I believe it was. And they showed this huge effect where they got rid of a lot of the beta amyloid plaques that I showed you the picture of before. That's a known component of Alzheimer's disease. And you can see on one side, they have all of the red. That's all the amyloid plaque. And then they have the other image. So it's the same brain before and after treatment. And you can see there's a huge reduction in the amount of areas that are lighting up that are showing those plaques. So it was incredibly exciting because they had seen this in mouse models before, but that was the first one that showed a really great reduction in the amount of beta amyloid in a human brain. And I believe that was their phase 1 or 2 trials. And then back in 2020, or it was 2019, they had these big phase 3 trials where they're actually using it on patients. And so basically we knew that this drug could eliminate beta amyloid, but we didn't know what that would mean for symptoms and if that would make a difference to people living with Alzheimer's disease. So basically answering that question of, what does it mean if we remove these plaques? What does that have any change in symptoms? Was the role of 2 really big trials, Engage and Emerge is what they were called. They always have cute names for drug trials. They usually stand for something, but something easy to remember. So just in brief, those 2 trials, there was about 3,285 people. It was in a lot of different sites and in many different countries, which was excellent. Whenever you have these studies, you always want to try to get as many different areas and as diverse a population as possible. They enrolled patients that had to have a diagnosis of mild cognitive impairment or very early stage Alzheimer's disease, and they had to have a positive amyloid PET scan. So again, I talked earlier about how those are usually only available in academic centers. It is an expensive scan. It's I think $10,000. It varies. Sometimes it's a couple $1,000. Sometimes it's up to $10,000, depending on what center you get it in. But it's not something that is available outside of a research center usually. Importantly, the study had lots of exclusion criteria. It was only for ages 50 to 85, so anyone over 85 was automatically excluded. They also excluded people that had a lot of what we call comorbid conditions, so other diseases they had. Heart disease was a big one. Anyone with really significant heart disease was not enrolled in the trial. And then there was a lot of other drugs they couldn't be taking if they were in the trial. So a big example was anticoagulation. So they could take like an aspirin, but things like, Eliquis or all of those more powerful anticoagulation. If you were on that, you couldn't be enrolled in the study. And it also included very few minorities. Even though it was in several countries, it was overwhelmingly white participants. They had very, very few people of African descent, very few Latinx people. And basically in this trial, patients received either placebo, low dose, or high dose of aducanumab, which is this monoclonal antibody. So anytime you see mab at the end of a drug, it means that it's actually an antibody that was designed to fight a specific thing. So you see a lot of these new developed drugs, I like see it on commercials a lot. Whenever it has mab on the end, it literally means that it's an antibody that's been created to pick out something and destroy it. So we have a lot of things that are for certain types of cancer. We have a lot of monoclonal antibodies that are for certain parts of your immune system. But anyway, anytime it has that mab ending, it means it was basically an antibody that was designed to go in and take out a certain thing. So in the case of aducanumab, it was an antibody that was specifically designed to target these amyloid proteins and get rid of them. So over 18 months, patients received IV infusions. Usually lasted anywhere from 45 minutes to an hour, and it was every 4 weeks, once a month, they got these infusions. So the primary endpoint, so that is what they were looking for to see if it made a difference, was the Clinical Dementia Rating Scale, or CDR, that's what we call it. It's a 5-point scale. It's used to characterize 6 different domains: memory, orientation, judgment and problem solving, community affairs, homes and hobbies, and personal care. So again, this is something that was developed to try to quantify the symptoms of Alzheimer's disease, because it's a really complicated thing and a hard thing to put into numbers, right? So how much are they struggling taking care of their home? Are they able to get out and do their hobbies? Do they need help with their personal care? Are they able to do it by themselves? And then some questions about orientation. Do they know where they are, what year it is, what day of the week, judgment and problem solving. So there was just a cognitive test, but it's made up mostly of questions. The study specifically used the sum of boxes, which is a composite score of all 6 domains. So I'll show you an example of this, but basically it's a 5-point scale, and it ranges from either 0, which is no impairment, 0.5, which is mild impairment, and then all the way to 3, which is severe impairment. So let me show you an example of that. So yeah, here's the example of the CDR. So for example, memory, 0 would be they have no memory loss. 0.5 would be, slight forgetfulness, and then mild would have, moderate memory loss, more marked for recent events. And then you go all the way to severe memory loss, only fragments remain. So again, here's that 5-point scale, and they used the sum of boxes where they looked at every single over all 6 domains and looked at the difference between all of them. So that was their primary endpoint. That's what they looked at the most, to see if there was any change in that on people that were on the drug versus people that were on the placebo. Does that kind of make sense about what they were looking for in the study? I'm seeing some nods. Okay, good.
We do have one question, Celeste.
Yeah.
Is the higher level of white participants in the drug trial in any way correlated to the incidence of dementia?
Oh, well, so no. There's actually, dementia is much more common in people of African descent, up to 2 times more common, depending on a lot of other factors. And it's unknown if this is a genetic predisposition or if it's a lot of socioeconomic factors, or if there's, geographic factors. It's really not known why, but there is a known increased risk in both African Americans, and then slightly less, but still an increased risk in Latinx patients. So in a way, it was kind of frustrating that the people that are arguably, more affected by this disease, and they have worse outcomes too. And so people that are more affected by this disease have worse outcomes, were not represented in this trial. And that was really infuriating to a lot of people, I think, with good reason.
Thank you.
That was a very good question. So for the results of these 2 trials, the studies were stopped early based on the results of futility analysis. And this was being conducted while the study was going on by an independent data monitoring committee. This is actually really common these days. It used to be that they would, blind everyone, and they would, look at all this study data and they would wait till the very end and they would unblind things and then they would examine the data. And that's really not the way things are done anymore. There's constantly churning over the data as it comes in. And then if they discover early on that either there's a very clear benefit or there's clearly not a benefit, they'll stop the trial early. So this happened recently with a bunch of drugs that were actually for diabetes, but they were using them for people with diabetes that had heart failure. And the results were so impressive because people were doing a lot better that they ended the study early because they said it's unethical to give only some patients this drug when we see that it works so well. So that's one example of why they would end a study early, is if they see that this is really effective. And another example is if they see this really isn't effective, these studies are unlikely to meet their endpoint. So we're just going to call it here and throw in the towel, basically, which is originally what they did for both the Emerge and Engage trials. But then they re-examined the data. So they had pooled the results from the two studies. And when they split them up into different studies and looked at very specific subgroups, they did see a statistically significant difference. So 7 months later, Biogen, which is the company that made Aduhelm, announced that when the studies were separated, there was a statistically significant difference in the placebo versus the high dose group. So both the low dose groups didn't show any effect, but the high dose group in one of the trials did show an effect. So all groups had worsening of those CDR scores, but the high dose group had a smaller change than the placebo group, specifically in the Emerge trial. So all drug groups in both studies showed dramatic reduction in the amount of beta amyloid plaques and some reduction in tau tangles. So again, it was very effective at getting rid of that amyloid. If you remember that picture from Nature where we had the picture of the brain and all of that signal was gone, they're still very effective at removing the amyloid, but less so with the clinical symptoms. So this is, again, taking a look at their primary endpoint. So you can see for this Engage trial here, this is the baseline of the scale, that's CDR, and a higher scale is worse. So everyone, got worse over time, which is absolutely expected for Alzheimer's disease. We know that that's how things progress. But you can see that the gray group, the placebo group, got more worse, or, the effect was greater than the high dose here. And you can see that wasn't true for the Engage trial. You can see they're kind of clustered there. There's not much of a separation. And in fact, the people on the high dose did slightly worse compared to the others. And there was, Biogen had a lot of reasons for why there was that result in the Engage trial. It gets a little bit complicated, but they had a specific subgroup of people that were positive for a mutation called the ApoE4 gene, which puts you at higher risk for Alzheimer's disease. And they thought that that subgroup had a higher rate of side effects and had to pause the drug more. So I'll get more into that if there's more questions about it. But basically, they had a lot of very fancy math to say, ignore this study for these reasons, look at this study and look specifically at this, and you can see that there is a difference. And then just to reiterate, they did see a definite reduction in those biomarkers that we talked about. So this is actually for the tau deposition, which was less dramatic than the amyloid, but the amyloid had very, very dramatic reduction in the amount of amyloid. And here they did have a moderate reduction in the amount of tau too, which is pretty exciting because the tau correlates more to damage than the amyloid does. So some people will have a lot of amyloid, but not a lot of symptoms, but tau does correlate a little bit more. People with more tau do tend to have more symptoms. So I want to talk briefly about the side effects of aducanumab. So the most significant side effect was amyloid-related imaging abnormalities, or ARIA, which is the short name for it. And it occurred in a lot of people, about 40% of the patients in the high-risk group. So this was something that was seen on MRI. So it shows a little bit of swelling and edema, and then some microbleeding, so little tiny bleeds around the vessels. And most of the time people were asymptomatic, but some people did have symptoms, and symptoms was about headache, confusion, dizziness, and nausea. So these are pretty serious side effects when you think about the population that we're working with, people that are at really high risk of falling, that could have devastating effects with falls, things like that. So ARIA usually resolved after stopping the drug, but many patients required pauses in their treatments because they would pause the treatment whenever they saw this ARIA, wait for it to resolve, and then often they would resume the treatment. And that was part of the reason they thought that the results from the Emerge may not have matched Engage was that there was a lot more people that had to pause in the Engage. So they thought that that might have accounted for them not seeing that effect, was because people often had to pause and didn't receive the full dose. So we don't know if ARIA had any long-term effects. The vast majority of people, the symptoms would go away when they paused the drug. It was only about 6% of the people that got the ARIA side effect that couldn't go back on the drug, that weren't able to resume it. Any questions about ARIA as a side effect? So we'll move on to the FDA approval. So based on the post-hoc analysis, meaning that, after the sort of looking backwards at the data, and then the Emerge trial, Biogen applied directly to the FDA for approval of aducanumab. In November of 2020, the Scientific Advisory Committee to the FDA recommended against approval of aducanumab to treat the cognitive effects of Alzheimer's disease. But in June 2020, the FDA actually ended up approving it. And they did approve it under specifically the accelerated approval pathway, which is kind of a unique pathway. So it approves drugs for serious or life-threatening illnesses that may provide meaningful therapeutic benefit over existing treatments when the drug is shown to have an effect on a surrogate endpoint that is reasonably likely to predict a clinical benefit to patients, and there remains some uncertainty about the drug's clinical benefit. So that was taken right from the FDA's website when they talk about what they mean by accelerated approval. So basically, they said that we're using this surrogate endpoint, meaning we're looking at this reduction in amyloid as potentially affecting the clinical markers. So they approved it not based on the fact that it slowed these clinical signs or slowed the symptoms of dementia. They approved it based on the fact that it cleared these amyloid plaques, and there was a reasonable assumption that that might affect clinical disease, which was not really what the Scientific Advisory Committee had voted on. They voted on whether they would approve this drug for a treatment for those symptoms. So it's important to see that distinction, that they had kind of changed what the endpoint was from symptoms and clinical change to the reduction in the amyloid. So this launched a huge controversy. So 3 of the committee members that were on the committee that advised against it quit and resigned their positions in protest. So this was a huge deal. There was a congressional hearing. It was a big deal. A lot of people thought that Biogen really worked too closely with the FDA because they had all of this data. So some people argued that the drug company did a great job of working with the FDA to help them analyze the data. They certainly did a lot of work on it. Other people said that their FDA was really too close to this drug company. There was a lot of meetings that they had that were kind of off the record and things like that, that weren't public hearings. A lot of meetings between Biogen and the FDA, and a lot of people thought that that relationship might be too close. So Medicare stated that only patients that are enrolled in clinical trials will be eligible for aducanumab. And that prompted some serious criticism from the Alzheimer's Association, who thought that was overly limiting. And there's just a lot of money at stake. This is a really, really expensive drug. Any of the MAB drugs are always expensive, again, because it's usually some specially designed antibody to go after a specific target, and that is expensive to produce. They originally stated it would cost about $56,000, and they later revised that down to $28,000. But there is a lot of money at stake, so I think that people thought that the FDA might have, or that there was just a lot of pressure and effect from Biogen because there was a lot of money at stake.
We have another question.
Yeah.
Did the results of the trial change thoughts on the role of amyloid plaque in the symptoms of dementia?
So that's a really excellent question. And the answer is yes, but not as much as you might think. So you're absolutely right that, so we call it the amyloid hypothesis. And we brought up, there was this, hotly debated, well, should we give up on this amyloid hypothesis? Is this what really causes the disease? Just because these plaques exist doesn't mean that that's what's necessarily causing the disease. And we still do think that amyloid is involved. We think the tau proteins are probably more important because, again, the amount of those correlates a little bit more with symptoms, but they're actually connected. It looks like you probably reach a critical mass of the beta amyloid, and then you get a really big tau response. And also when we saw the reduction of beta amyloid, we did see reduction in inflammatory markers, which do correlate well with disease. So we discovered it's a lot more complicated than we thought. We thought it was just amyloid equals Alzheimer's, and it turns out to be way more complicated. It is definitely still involved, though. So we're not, giving up on the amyloid hypothesis. Amyloid definitely is involved, but the relationship that it plays with this other protein, the tau protein, also the relationship that it plays with other inflammatory markers is a lot more complicated than we initially suspected. It would be wonderful if we could have a mAb drug, one of those antibodies that could target the tau protein specifically, but that's a lot more difficult because they are intracellular, they're inside the cell. So it's a lot harder to go after them. And just by the nature of the protein, because there are other tau proteins, so you need it to go after only the misformed ones, not all of them. So it just gets complicated quickly. So a lot of people question the amyloid, and it's still hotly debated. There's a lot of people that say that we're too attached to the amyloid hypothesis and that we need to kind of move on. Other people say it's definitely involved. We just don't know all the roles. So at the very least, it didn't play the role that we thought it did. I do think it is, and most neurologists think that it probably is still involved in some way, but the relationship is definitely more complicated than we thought at first. But very good question. I was going to talk about lecanemab. So this is brand new. This was sponsored by a Japanese company, and they actually worked with Biogen. Biogen paid for half the development, but then they get half the profits when they come over to the US, I guess. It is another mAb drug, so another one of those monoclonal antibodies, and it's also targeting amyloid. Importantly, it is targeting a different form. So there's what we call the amyloid cascade that sort of leads to the formation of these plaques. And there's different, there's sort of a cycle of things that happens that trips one thing and then the other. So this one targets the soluble amyloid when it's just sort of free in the bloodstream, rather than when it's already in those plaques in the vessels. So because it targeted a different point in that pathway, it is significantly different in that way. The trial enrolled about 1,700 patients aged 50 to 90 years. So they still had an age cutoff, which I think is kind of unfortunate when you're studying a disease that is more common with age, but at least it was to 90 and not 85. Again, it was only people with mild cognitive impairment and early stage Alzheimer's disease. Their composite scores were actually even a little bit better than the Emerge and Engage trials. So in general, they had slightly better scores overall. So it was even more mild mild cognitive impairment or very mild early Alzheimer's dementia. I'm gonna take a sip of water. So again, the study was over 18 months. Again, it was IV infusions. This time it was every 2 weeks rather than once a month. And they used the same endpoint. So that's our clinical dementia rating scale, the sum of boxes. So that form that we saw earlier, asking the questions on that scale of 0 to 3, and then looking for any change in that and see if there was a difference in the change over time. So they also looked at amyloid and tau deposition, as well as several other cognitive tests and some measures of activities of daily living as well. So I kind of already talked about some of these, but some of the differences between aducanumab and lecanemab. Lecanemab targets the amyloid when it's soluble in the blood, not when it's already adhered to the vessel walls. Lecanemab really did a few things right. They published their study in a peer-reviewed journal in the New England Journal of Medicine, which is sort of the way that things are normally done. Normally, you publish a study and it's able to be reviewed by peers. They can talk about it. It enters sort of the scientific community dialogue about it. And that's something that they didn't do with aducanumab, which they received a lot of criticism for because they went directly to the FDA with those studies. And they did have a website where they published those studies for people to look at, but it wasn't the same as, publishing that in a peer-reviewed journal and kind of giving the scientific community a chance to respond to that. So that was something that lecanemab did better. Patients did have confirmed amyloid pathology. So again, to be enrolled in the trial, you had to have confirmed amyloid in the brain. And they did use those same PET scans, but they also used the CSF studies, which I think is important because those are much more widely available and much, much cheaper. That's a very easy test to perform. And it's $100 as opposed to $10,000. So I thought it was good that they had more than just the PET scans to decide if someone had amyloid. And it does make sense to include only people that had positive amyloid, even though that's not widely available. It kind of makes sense if you're going to be testing a drug that clears amyloid to make sure someone has amyloid first. So, and then although still underrepresented, the study at least attempted to include more minority groups. It was still pretty sad showing, but they did at least talk about it and address it and try to get a few more different people involved. So briefly, the results of the lecanemab trial. They did have a statistically significant reduction. And again, it's that change in that CDR, so that's the clinical dementia range, as sum of boxes score. Overall, yeah, 27% reduction. So there was, again, a change over time, but there was less of a change for people that were on the drug. Some people responded more or less to the drug, but the average difference between the placebo group and the drug group was 0.45 points out of that 18-point scale. So again, when we were looking at that 0 to 3 over all 6 of those domains, the difference between people that were on the drug versus not was about 0.4 or 27%. There was a significant reduction in amyloid plaques. Importantly, this was the only study that had some quality of life questionnaires, and it did show improved scores on quality of life questionnaires for both the patients and the caregivers. So that was really, really significant. A lot of the drugs that we have for Alzheimer's disease do not show, improved quality of life. So I was impressed by that. So we'll go over some of the graphs. So again, this is just showing these two different lines. Here's the people that were on the drug, the people that were not, and then the difference in their scores over time. And again, this is kind of the reverse of the one we had before, where higher was worse. This one, higher is better, I guess, because we're looking at the change. So they just had a different way of writing the same thing. So in terms of some of the other things that they looked at besides the clinical dementia rating scale, the amyloid burden on PET scan, you can see that was a huge difference. So as you would expect, people that were on the placebo had no change in the amount of amyloid. If anything, they had more amyloid in their brain over time, which makes sense. That's what we expect from this disease. Versus people that were on the drug had this huge reduction in amyloid. So that's a very clear, effect there. But that's very similar to the aducanumab too. It definitely clears amyloid, that we know. These are some other scales that we frequently use. This is the Alzheimer's Dementia Cognitive. I actually forget what it stands for, but it's another one of those scales. I have it written down. Oh, Alzheimer's Disease Composite Score. That's what the ADCOM stands for. And that's a 23-item scale. And it does include the instrumental activities of daily living, and it kind of measures how much people are able to do on their own and how well they're functioning. And then the MCI ADL score is one that, importantly, they ask the caregivers what the patient's able to do on their own. So rather than asking the patient or having a third-party observer, they ask the caregivers what the patient can do by themselves or what they need help with. So again, in all of these, there was a statistically significant improvement on people that were on that medicine. And then I want to talk about the side effects. So we saw the exact same side effect that we did with aducanumab, mainly the ARIA. It was a lot less, though. So if you remember, in the high-dose aducanumab group, it was 40%. In the lecanemab, they actually split it up into people that had either the edema or the microhemorrhages. So about 12% of the people that were on the drug versus about 1.7% of the placebo had that effect. And then for the little microhemorrhages, they had about 14% of the people versus 7% that was on the placebo. So you can see these things happen even to people that aren't on the drug, but there's a definite increase in the rate that this happens for people that are on the drug. And I was trying really hard to figure out if there were some people that they put in both groups that had both edema and microhemorrhages, because some people definitely did have both. So I wasn't sure if for the total number that had any ARIA, it would be these numbers added together, if it would be, I guess, 26%. But even if it was, that would still be a lot less than the 40% that we saw with the aducanumab. So does that make sense? So we saw the same side effect to a lesser degree than the other drug, but it was definitely still present. Absolutely a risk for this drug. So other risks, there were 2 deaths in the lecanemab study. They may have been related to the drug causing bleeding in the brain. So both these patients died from bleeding in the brain. They were both on really high dose IV anticoagulation, which by itself can cause bleeding in the brain, and can, people die from that treatment by itself all the time. So it's really hard to know if this drug was a contributing factor at all. Because we know that it causes those microhemorrhages and bleeding in the brain, it's certainly, reasonable to think that it might contribute to that. But we definitely don't know for sure, because again, people have bleeding in their brain when they're on that high dose IV anticoagulation all the time. So it's kind of impossible to know at this point if that contributed or if it had no effect at all. It's just impossible to know. So we're really going to need some retrospective safety monitoring, because we just don't have the numbers. I think the only way to tell for sure if this drug does contribute to the risk of bleeding is when we have thousands of people on it for years, and we're able to look back at the rates and see if more people died on IV anticoagulation. There is some talk about maybe people that are on high dose anticoagulation shouldn't be eligible for the drug, and that's an area of debate right now. Because there is the concern, again, it would be reasonable to think that it might, because we know that it causes these microhemorrhages, but we don't know if it contributes to the major hemorrhaging. Because again, people that get that level of anticoagulation certainly can have major bleeds when they're not on the drug. So it's really hard to tease out if that's contributing at all. So the FDA did grant accelerated approval, and that was just January of this year. So this is kind of recent stuff that's happening. You might have seen some articles about it. But again, that was under that accelerated approval where I read you that paragraph from the FDA's website. So they have submitted an application for full approval, and that would really change the game if they did get full approval, because then many insurance companies and of course Medicaid particularly would be obligated to pay for it if it was FDA covered under their full approval. And so that would really change the game because it would start being covered. And it's expected to be around $26,000 a year. So about the same as aducanumab once they reduce the price. So basically, in summary, the amyloid monoclonal antibodies are very effective at removing plaques from the brain. They likely have a mild effect on preserving cognitive function and therefore may be beneficial for some patients in the very early stages of the disease. And I want to say that even the drug's biggest cheerleaders and proponents all admit that the effect is pretty mild. 27% reduction sounds pretty dramatic when you say it. When you look at the change in the scores, again, it's about 0.45 out of an 18-point scale. So it's not a dramatic effect by anyone's standards, but there is an observable effect that we're seeing that does seem to be, statistically significant. And that's a big deal because we don't have many things that show that in the treatment of Alzheimer's disease. The drugs do have definite risks and warrant an in-depth discussion with a specialist about whether you would be at high risk for certain side effects. I mentioned really briefly that the ApoE4 puts you at higher risk of having Alzheimer's disease. And people with that variant were much more likely to have the ARIA, specifically the microhemorrhages. And people can either have one copy of the gene or two, but people that had two copies were very, very high risk of having ARIA and bleeding. So there's a lot of talk about maybe people should be screened for that, and maybe they should not allow homozygotes, people with two copies of the gene. And then some people think they shouldn't allow heterozygotes. And then there was some debate back and forth about whether those people benefited as much from the drug. But there's some evidence that their risks are higher and they may not benefit as much. So there's some debate about what role that should play. Basically, before I would recommend this drug to any one of my patients, there would be some real work to do to see if they had any elevated risk factors. This is a really rapidly developing field. There's a bunch of studies in the works. A lot of people think that when we're intervening at the MCI stage, it might actually be a little bit too late. And there's a lot of studies going on right now for people that are asymptomatic. So before they have really large builds up of amyloid. And, a lot of people think intervening at that stage might show people that don't develop the same symptoms. And we just don't know yet, but these studies are happening right now. And I think we'll know a lot more about the pathophysiology of Alzheimer's disease in the next 5 to 10 years. So it's a little bit frustrating because we're in the weeds right now. We keep getting these studies that are kind of confusing, that don't have really great results, but we are making some progress. And I do think that we're going to know a lot more in about 5 years. So that was mostly what I wanted to talk about with the drugs. Let me open it up for questions or comments or. anything.
There's one question in the chat box. Is there a recommended time length for patients to be on these medications?
So that's a good question. Both of the trials were 18 months. So we don't know about longer. There's other trials that are doing longer term therapy. Some people think that you might see a bigger effect over time. There was, for the lecanemab study specifically, there was a separation after about 3 to 6 months, and then the separation stayed pretty constant until the 18 months. So they're not sure if you get the most benefit in the first 3 to 6 months, and after that you don't get benefit, or maybe there'll be another time when they separate further. So we don't know yet. Those studies are happening right now. The biggest, so we look at the 2 lines and see when they start to separate in terms of their outcomes, and we see that separation somewhere around 3 to 6 months. And after about 6 months, they stayed pretty constant in their relationship to each other, but that's unknown if it's going to stay that way.
Are there non-medical interventions showing any real progress in symptoms of the disease?
I love whoever asked that question, because that, I think, is something that we do not talk enough about. So when we talk about what is most effective for people living with Alzheimer's to live better lives and help them and their families, it absolutely is not a drug. It's the non-pharmacological interventions, having wraparound dementia care, having a place like the Adult Day Center or other places where caregivers can get some break and also can get education about how to deal with some of the behavioral aspects, to how to, deal with things that come up with Alzheimer's disease. Having a healthy diet and exercise makes a huge difference in the progression of Alzheimer's disease, and also in your risk for developing the disease in the first place. I was at a conference, and they were presenting this, they had this comprehensive dementia program. They were presenting how much better the outcomes were with that, how much better people's lives were, their quality of life scores. And it was just this really, really dramatic change. And they were talking about how they were really frustrated because they couldn't, and it had things like finding a physical therapist for someone, having longer appointments with your provider. And people were talking about, oh, how that was unsustainable. And, we couldn't spend money for that. And we're saying, gosh, we're spending, $56,000 a year on drugs that may or may not work, and we can't, and things that we know work, but we can't get those funded because they're not a drug. I mean, if we could put lifestyle interventions in a pill, you would just make $1 million, because it would be by far the most effective treatment that we have. There was a kind of a dark comment that I thought was pretty funny. So at that conference where they presented all of these things that really work and how great this program was, and we had not mentioned these monoclonal antibodies at all. We hadn't mentioned aducanumab, but it's always kind of in the background in the geriatrics world. And someone stood up and said, well, I bet we could get this covered if we called it, so the program is called Comprehensive Dementia Care. And they said, if we called it Comprehensive Dementia Care MAB, then I bet we get it covered. And so the joke was that they were putting that MAB antibody at the end, and then it would be covered. But, it's kind of a dark thing, but it's kind of true that it's unfortunately a lot easier to get a drug covered than things that have to do with lifestyle, even though those things that have to do with lifestyle are definitely more effective.
Another question was, due to the high cost and expected use, will Medicare premiums go up like they did with the A drug?
So there's been lots of debate about that. There's lots of articles about how this was going to break Medicare and all of that. Currently the aducanumab Medicare doesn't really pay for aducanumab, because the only people that are getting it are on the studies, and usually the studies pay for that. So as of yet, I don't think it's resulted in a big change in Medicare premium. Certainly a lot of fear around it. If the other drug gets general FDA approval, then I think that might be a game changer. I don't know if Medicare would cover it, but there's certainly be a lot of pressure for them to cover it. And so I honestly don't know what the economic impact of that would be. I don't know much about insurance coverage and what that would mean for them.
Does anyone else have any other questions for Celeste?
Those are really good questions, guys.
Well, I guess that will be the end of our presentation. Thank you, Celeste, for your time today. I just wanted to let everyone know that at the end of this workshop, There's a survey. And yes, Lori, we will be sending out a certificate for completion. And I will also be entering in the chat box the registration for our next workshop, which will be on managing those dementia-related behaviors that we kind of you briefly touched on at the end. So we'll be talking
by far
about
one of the most important things that people living with Alzheimer's and their families can do.
And last call for questions. We got a bunch of thank yous for you, Celeste.
Thanks, guys.
Wonderful presentation. All right, that will be the end of it. We hope to see everyone at our next workshop. Thank you.
Thanks, guys.
Thank you, Celeste.